Hello and welcome. Moss Adams is pleased that you've joined us for the first session in our 2023 Healthcare Executive Webcast Series, The Future of Reimbursement Through the Lens of CMS. Before we begin, I'm going to play a brief video.
Welcome, and thanks for joining. We're pleased to present our continuing professional education webcast series. Before we begin, please keep the following in mind. You can customize how you view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can adjust window size and placement or enter full screen mode using the controls at the top right of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons that relate to a different aspect of our session. You can download a PDF of today's slides from the Slide Deck and Handouts widget. You can ask questions by typing in the Q&A window and clicking Submit. We'll do our best to answer all questions or follow up via email. If you experience technical difficulty, refresh your browser by hitting the F5 key. Today's session offers 1 CPE credit. To receive credit, you must meet the National Association of State Boards of Accountancy requirements. You must attend at least 50 minutes of the session and respond to at least 75% of polling questions. To participate in the polls, please check the button next to your answer within the slide window and click Submit. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget and download your CPE certificate. Don't worry if you can't download your CPE certificate today. We'll email you a copy in 2 weeks. If attending this webcast in a group, you must complete our group CPE attendance sheet, available in our Slide Deck and Handouts widget to receive credit. Please have all group members sign it and send only 1 sheet per group. CPE credit can only be awarded to participants registered as themselves and isn't available for participants who view the on-demand version. This presentation is not legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
All right. I do want to note that today's session is more of a fireside chat. However, please make sure to keep your slide window open since that is where we will be doing the polling questions. And you will need to respond to at least 3 of the 5 polling questions that we pull up throughout the presentation. And now I would like to turn it over to Eric Luzgas, Managing Director here at Moss Adams. Eric, the floor is yours.
Hi, I'm Eric Luzgas. As she said, I'm one of the newest members of the healthcare consulting team after spending the past 20 years leading the reimbursement department for one of the country's larger healthcare systems. During my time on the provider side of the house, it was critical to stay on top of the latest information regarding the reimbursement of our hospitals and physicians. Given that, I'm excited to welcome you to our first quarterly executive webcast of 2023, The Future of Reimbursement Through the Lens of CMS and CMMI. This webcast follows on the heels of our webcast held last month, The Future of Reimbursement Through the Lens of MedPAC, which was part of our 2022 annual healthcare conference, where today's guest, Susan Dentzer, had a compelling conversation with Mike Chernow, where he shared insights on both chair of MedPAC as well as his views as his role at the Leonard Schaefer Professor of Healthcare Policy and the Director of Healthcare Markets and Regulation Lab in the Department of Healthcare Policy at Harvard Medical School. Each year, Moss Adams hosts an annual healthcare conference for executives across the healthcare continuum. Just this past November, we had several interesting sessions discussing a variety of healthcare topics, including the State of the Union presented by Ford Coles of the Advisory Board, how California's SB 184 could impact healthcare state regulation across the country, the urgency of behavioral health integration, and much more. The information is still relevant, and these sessions are available to watch on demand. The link to view these at your leisure is also on your console. On that note, I'd like to share that our 2023 Healthcare Executive Conference will be held again in Las Vegas this year. Mark your calendars for November 1st through the 3rd, and please save the date. If you're interested in getting on the mailing list for the conference, in the webcast console, you will see a link. And with that in mind, let's go ahead and start some of the polling questions. Amy, can you cue those up? First, which best describes your organization? A, hospital, B, integrated health system, C, physician medical group, D, health plan, E, long-term care provider, F, ancillary provider, G, self-insured employer, H, other. And just a reminder, we need to do the polling questions in order to provide CPE.
And Eric, while people are responding, I do want to jump in. I see a lot of people submitting it through the Q&A window. You do need to respond on the slide itself to get your CPE. So you're going to select the button and then make sure you hit submit.
Okay, we got an excellent mix that this session will be perfect for. Okay, let's go to the next polling question. What percentage of your revenue is derived from government reimbursement, Medicare, Medicaid, and other state and local funding? Less than 25%, between 25 and 50, or more than 50%? We got the poll results. More than 50% wins the day on this one. Then this is very relevant. Let's go to the third poll question. In 2023, how is your organization's outlook on financial performance? A, doing well, seeing positive margins on target to meet our projections and growth goals. B, just about breaking even. C, experiencing moderate loss, and D, experiencing large financial losses. That's great. A, seeing positive margins. This is a bit of a flip from the last time we did this, so that seems like we're on a little bit of a rebound. That's fantastic. Do we have any more? Are we ready to go, Amy?
We have one more in this.
One more. Okay. What best describes your organization's state of readiness for continued low or shrinking public program payment? A, we're ready. We've been preparing for this for a long time. B, we think we're ready. We've been partnering with providers and payers to strategize on evolving reimbursement models and changing payer mix. C, we will have to make major changes in structure and operations. D, we are not likely to survive. And E, not sure. A mixed bag here. Yeah, great. Well, the more information, the better. So with that, let's go ahead and get into the webcast. Without further ado, let me introduce Susan Dentzer. Susan Dentzer is the president and CEO of America's Physician Group, a not-for-profit organization representing roughly 350 large physician groups focused on patient-centered, coordinated and integrated healthcare, responsible and accountable for both cost and quality. Dentzer is a highly respected health policy thought leader, frequent speaker and commentator, and author of commentaries in Modern Healthcare, New England Journal of Medicine Catalyst, American Journal of Public Health, and other peer-reviewed publications. She is also the editor and lead author of the book Healthcare Without Walls, a roadmap for reinventing U.S. healthcare. With that, Susan?
Eric, thank you so much. It's great to be with you and everybody else on this webcast today. And hello to our guests, Meena, Seshamani, and Liz Fowler. Meena holds both a medical degree and a PhD. She's the Deputy Administrator and Director of the Center for Medicare at CMS. Liz holds both a Juris Doctor law degree and a PhD. She's the Director of the Center for Medicare and Medicaid Innovation, also known as the Innovation Center, and also a Deputy Administrator at CMS. These are quite talented and experienced people, and links to their bios are on your screen. I do commend those to you. But to orient our audience, Meena and Liz, let's start by clarifying your respective roles at the Center for Medicare and at CMS, and also, of course, at Liz, your role at CMMI. So Meena, let's start with you on that.
Great. Well, thank you so much for having both of us here today. So I lead the Center for Medicare, which is the focal point for the policies and operations of the Medicare program, serving more than 63 million people, those age 65 and older, and stage renal disease, people with disabilities. And, you know, I think as part of that, really being able to leverage the Medicare program to drive the kind of change that we want and need in the health system, right? We process almost $1 trillion in claims each year, partner with more than 1 million clinicians, 6,000 hospitals. And so where Medicare makes changes, many others partner and follow suit. And so to be able to leverage the Medicare program to advance health equity, to drive innovation for high quality whole person care, to make sure that the program is working for the people that we serve, those are all really tenets that guide a lot of the work that we do. And the work that we do in partnership with the Innovation Center, where, you know, my colleague will speak a bit more, where we have this unique partnership to be able to have the Innovation Center test new ideas and new care delivery models. And if something works, to be able to then incorporate that and scale that in the Medicare program writ large.
Great. Thanks, Meena. And Liz, that's a great handoff to you and your role, but tell us more.
Sure, thanks. And first, let me start by thanking you for inviting us to join you today. I'm really thrilled to be here with my colleague, Dr. Meena Seshamani, to provide an update on what we've been up to since we last talked. And as you explained, I lead the Center for Medicare and Medicaid Innovation, sometimes called the CMS Innovation Center and often just called CMMI. For those who aren't familiar with the Innovation Center, we were part of the Affordable Care Act. It was created as a novel approach to test new healthcare payment and delivery system models in Medicare and Medicaid. As Don Berwick, a former CMS administrator and one of the nation's foremost experts on delivery system reform, described it, the Innovation Center is to the U.S. health system what the NIH is to biomedical research. As part of a model or a demonstration, we have broad authority to waive Medicare rules and regulations that stand in the way of improving care delivery and incentivizing coordinated, person-centered, and value-based care. Our authority in Medicaid is less expansive than it is in Medicare. And as Meena said, we've developed this partnership where we're trying to make sure that whatever we're doing is relevant to the Medicare program as a whole, and that what we're testing can potentially be scaled into the Medicare program.
Great. Thank you both. And of course, the history books will record that Liz was on the Senate staff at the Senate Finance Committee that wrote the portion of the Affordable Care Act that created the Innovation Center. So now she's circled back in this very important role leading the center. So as you all saw in the poll results, there are a lot of organizations represented on this call today that are engaging in the move to value, as it is commonly phrased, through new reimbursement models. So that's a really good jumping off point for us to talk about the strategy that CMS and CMMI have articulated in a number of publications over the last year or so for moving Medicare, and by extension, the rest of U.S. healthcare, more decisively into value-based care. And as you all have said, the target goal is to get all of the roughly 30 million of Medicare beneficiaries who are in the traditional part of the program, not in Medicare Advantage, but the traditional part of the program, into accountable care relationships with their providers by 2030. So there are about 1 in 3 of those beneficiaries in ACOs, for example, today, which is one definition, obviously, of an accountable relationship. But let's start talking about this goal of getting all of those beneficiaries into accountable models. It's been estimated that means, roughly speaking, getting about 4 million more beneficiaries each year into these models. So let's talk about that goal. Where are we in terms of meeting that goal? And are we going to be able to get our collective feet on the gas pedal fast enough to get all these beneficiaries into accountable relationships by 2030? Meena, let's start with you on that.
Great, thank you. And, I will say that the move to value-based care, the move to more holistic care models is something that's very personal for me. As a physician taking care of patients, leading care transformation for a major health system, where there were so many times when I was taking care of a patient and knowing that there was much more impacting that person's health than just whatever was that episodic care that I provided when they came into my office. And so where we can really support the move towards models that encourage team-based approaches to care, where you're thinking about someone's health-related social needs and how can that be addressed, and really moving care upstream to the community, I think that is central to the work that Liz and I are doing together. And so to that end, to piggyback off of where we left off with the last question, a lot of the work that we did in the physician fee schedule last year was really trying to make pretty substantive changes to the Medicare Shared Savings Program, which is the largest value-based care program that's run through the Center for Medicare, where we incorporated something that was working in the Innovation Center around providing upfront investment dollars to providers to be able to join, an accountable care organization. And now we want to scale that writ large through the Medicare program, through MSSP. We're also looking at ways to encourage more participation by allowing upside risk for longer, looking in partnership with the Innovation Center about financial benchmarks. And I think you will see all of these changes take root as we move forward to make sure that we are creating an environment where it makes sense for providers to engage in these kinds of models and where we can reward good work that these models then enable. And I'll turn to my colleague to say more.
Great. Liz, pick up on that. This movement, this key goal now to get more traditional Medicare beneficiaries into accountable care relationships and meeting this goal of 30 million total. It's obviously going to be more than that by 2030. Where are we on that journey in your view?
So I think we have, as you said, set a pretty bold goal of having 100% of Medicare beneficiaries in an accountable care relationship with a provider who's responsible for total cost of care and quality by 2030. And I want to you asked about a definition and how we would define it. And to us, that means a longitudinal, accountable relationship between patients and providers. It can be through advanced primary care or through an accountable care organization like an ACO. And you think of this as making sure patients have a provider that's quarterbacking their care across settings and across other providers to make sure their needs are addressed and that the care they're receiving supports their goals. And I think if you're a beneficiary and maybe you're signed up for Medicare Advantage for one reason or another, but maybe you don't want a narrower network or limits on which providers you can see, we think that an ACO or an accountable care relationship is the alternative in traditional Medicare, where you can still see any doctor you want, but there's somebody looking out and making sure that that care is managed. And I just want to say that I have been personally visiting some of these sites and meeting with ACOs, their providers, and with patients who are benefiting from these innovations. And, you know, I'm not a physician like Meena who's had hands-on experience, but what I've seen really has confirmed that this is the right goal and the right strategy. So we have a long ways to go. I think we are continuing to work hand in glove with the Center for Medicare and making sure that what we're testing in the Innovation Center is relevant to the Medicare Shared Savings Program, which Meena runs. So we're coordinating very closely on what those innovations should be, what we should be testing. And I think you'll see us do more testing in the future of using the MSSP program as a chassis for some of these tests. So instead of creating a separate model test with separate organizations, embedding some of what we're testing within this larger program. I think that's one way we're aiming to make sure that we're going to be able to meet our goal by 2030.
Great, and we'll circle back to learn more about that. So as we know, there have been both areas of distinctive progress as well as setbacks in this move to value within Medicare. The happy news is that there is a growing number of Medicare beneficiaries attributed to an ACO. The setback has been in the number of organizations participating in these models. And last week, as you all know, CMS released data showing drops in the number of ACOs in the Medicare Shared Savings Program from about 480 roughly to roughly 456 in 2023. The number of assigned beneficiaries also fell a bit. And then when we move over to another model, which is now ACO REACH or direct contracting, a number of those organizations that were participating in that program last year are not continuing into the 2023 performance year. So setbacks there as well. To what do you all attribute these setbacks at this moment, at least in terms of the numbers of organizations participating in these two signal programs? Meena, let me start with you on that.
Great, thank you. I will say that, in fact, when you look at the number of ACOs and the number of participants overall, it has grown. We're at 700,000 provider organizations and 13 million people with Medicare, because you have to look at all of the various, value-based care programs. And a lot of what we've been talking about, we're laying the groundwork for growth to come. For example, one of the things that I have heard as I have been traveling the country, particularly from smaller providers, is that they need some money up front to be able to invest in the infrastructure to engage in these kinds of models. And so where we are now going to be providing that kind of investment up front, I think will make a huge difference coming up in terms of participation in these models. And I also think some of the policies that we're proposing will enable providers to see themselves in these programs. And what do I mean by that? Where we are investing in advancing health equity, where there are providers who are caring for underserved populations, we are now going to have a health equity adjustment where there's a reward, there's additional funding when someone is taking excellent care of underserved populations, and where providers can see that benefit, where the good work that they want to do is now being rewarded in the program. I think that will also not only encourage participation, but also help to guide that participation and kind of where to focus. And honing in on that last point, again, I know this from, having lived on the other side. It's important not just to put out a program, but to actually support those who want to engage. And so we are working very closely with our sister agencies like the Health Resources and Services Administration that provide technical assistance to rural providers, with the Administration for Community Living, where they have deep roots in local communities with the area agencies on aging, so that we can really galvanize the entire community to engage in providing support to healthcare providers as they are engaging in these models as well. So that technical assistance, support going the last mile, facilitating sharing of best practices across ACOs, that is also going to be key for the growth that we want to see and drive.
And Liz, since it's been brought up, the advanced investment model, that is an approach that actually was tested initially by you all in the Innovation Center and was pronounced a success, as Meena indicated, and now is being applied in the Medicare Shared Savings Program. Let's talk about what you learned about that advanced investment model through the test, and then we'll add a little bit more detail on what that amount is going to be that's now available in the MSSP program. So start with what we learned.
Sure. Well, I think, and Meena described it well, what we learned from the advanced investment model, or AIM, is now incorporated or going to be incorporated in the permanent program, the MSSP program, as the advanced investment payment program. And I think, just as Meena described, what we learned was that some of these organizations that may be less well resourced or less have maybe less capital to invest in some of the innovations and the infrastructure and the tools needed to be successful in a value-based care arrangement, giving that money up front, I think, can allow them to participate in these models in greater numbers. So just going back to your original question, I think we don't see this as a setback. I think we see this as a period where we're laying the groundwork for what's going to be an expansion of the program into the future. And you mentioned the ACO REACH program. We see that as growing in this year. So 84 of the 99 participants in 2022 remain part of the model. And we have added 48 new organizations for 2023. And more importantly, we also doubled representation of safety net providers in the program. An estimated over 800 providers are either federally qualified health centers, rural health centers, or critical access hospitals, compared to about 400 in 2022. And, you know, this requires that work with HRSA and our partners at ACL, just as Meena described. And we're all engaged in those discussions and figuring out how to bring these programs into the future and make sure that they're strong and vibrant and able to meet the goals that we've laid out.
Great. Okay, thank you very much for that. So one of the challenges, obviously, as you've noted, is it's very hard for providers who are not engaged in taking on financial risk, responsibility for the total cost of care, to make that transition. And the AIM approach is designed to help compensate them for that. In MSSP, it's going to be a $250,000 payment. Just, Meena, is that going to be enough, particularly given the extreme financial circumstances some providers are up against? We saw the response to the poll earlier. There is not a not insignificant group of providers in this country that is worried about actually survival at this point. How do we think about the degree to which that AIM payment is actually going to help providers make the decision to move into MSSP, even if they're not taking on full upside and downside risk initially? And in fact, under the new approach, they have a longer time than ever to stay in upside only risk. Is this all going to be enough to enable them to move along the continuum? First of all, to get into the program and then move along the continuum. Meena, this is for you.
Great. Yeah. I think, Susan, you raised a good point, which is that the advanced investment payments is just one of many changes that are being made. You know, enabling more time and upside only risk, making changes to the financial benchmark, and with our colleagues in the Innovation Center, we did a request for information to get further ideas for how we can further adjust the models. And I think the other piece is, we all have learned a lot from the COVID pandemic, and that is an understatement. And where there are opportunities now for all of us to leverage where we need to invest more in population health, and where healthcare providers want the opportunity to be able to care for people in a way that makes more sense. I think there is an imperative to really support that, you know, being in some of these models can help support. And I think the last point I would make, piggybacking off what we said, that this is just one of several pieces, is that we are also thinking not just about ACOs, but how do we support support changes in care delivery across our programs. So thinking about traditional, fee-for-service and the MIPS program, thinking about telehealth, the recent omnibus now extended telehealth for 2 years, and the opportunity to be able to see what are the benefits of telehealth, what are the impacts on utilization, outcomes, cost moving forward, and thinking about Medicare Advantage as well, because there are many pieces to this puzzle that we need to think about together, and we need to align across our programs and really address issues of equity and then encourage the growth of these models.
Liz, do you want to build on that as you just think about additional tests that CMMI will be engaged in? You referenced earlier conducting tests within the context of MSSP. What, for example, might you want to test at this point?
Well, I think some of the things that we're testing in the ACO REACH program may have relevance to MSSP, and we're in discussions with Meena, for example, primary care capitation or prepayment for primary care services. That's one. We have ACO REACH is one of the highest risk models that we've ever run at CMMI, and maybe there are concepts, given the number of applicants we received, we know there's interest in taking on more risk. And so that's something that we're exploring with the Shared Savings Program team. We're also thinking about the health equity elements, and Meena laid out some of those in her remarks, but we are testing a very novel approach which adjusts the benchmark payment for providers that are serving higher proportions of underserved populations. And that includes historically disadvantaged populations and rural populations. So maybe $30 per member per month bump isn't enough, but we'll see if that makes a difference. And maybe we're measuring and determining who is serving those populations in the right way, but we're testing different approaches to that measurement as well. Those are also aspects we're considering. I think specialty care is another one, and thinking about the future of our episode-based payment models and making sure, and frankly, Susan, one of the things that came from our strategy refresh was that some of our models were sort of conflicting with each other. The incentives in the episode or bundled payment model conflicted with some of the ACOs and drew away from participants, from practitioners joining an ACO. So we want to make sure that all of these efforts are working in harmony. And so that's why we're thinking maybe some of these episode models could be embedded in the MSSP program, for example. So that's another area that we're exploring with Meena and her team.
Great. Thanks so much. So Meena, you brought up the notion of benchmarks. And this is an area that is of increasing interest and concern, obviously, partly because of the growth of the Medicare Advantage program, which is closed probably this year will constitute a half of all Medicare beneficiary enrollment. As that program continues to grow, using benchmarks that are drawn out of the traditional experience in traditional Medicare are less and less relevant, yet that's where we are in terms of benchmarking for MSSP. You all have put out a request for information about moving to, for example, administrative benchmarks, basically cutting the tie between historical Medicare spending experience and the setting of new benchmarks. You've obviously gotten a lot of opinions back on that. Where does your thinking stand at this point on changing the benchmarks? Because as we know, where the benchmarks are is a fundamental determinant of who wants to get into these programs.
Yeah, well, Susan, you mentioned that request for information. And so just for context for everyone, we had put out a request for information in July on the Medicare Advantage program, and how we can really leverage the Medicare Advantage program to drive some of the key goals that we've been talking about in this discussion: advancing health equity, driving innovation to support high quality whole person care, expanding access to affordable coverage and care, and being good stewards of the program, promoting market competition, transparency, and utilizing a data-driven approach. We received roughly 4,000 comments across the spectrum to this request for information. And that information is now helping inform the policy making that we're doing. So, we recently proposed our C&D rule, Medicare Advantage and Part D rule, and in there, we really looked towards how can we improve Medicare Advantage so it continues to drive towards these goals? So thinking about prior authorization and, reining in misleading marketing practices, supporting behavioral health through Medicare Advantage. And I think with these kinds of changes, and some of what you mentioned around benchmarking, we always need to think about where the Medicare statute is, and then where we have the opportunity from that regulatory administrative authority to be able to drive changes and to really do so in partnership with everyone else. It's so important to us to hear from people on the ground what their experiences are, where they see opportunities that can inform our policies and operations. And then in turn, we partner on the ground to make sure that what we're putting into place in, say, a regulation at the 25,000 foot level comes to life on the ground.
So it may be premature to ask you whether you've developed any clear path forward coming out of the responses to the RFI, but what are you thinking now around administrative benchmarking?
And I'll start, and Liz should chime in. I think, this is some of where we received comments through our request for information, not just for Medicare Advantage, but also the Innovation Center with us had a request for information in the physician fee schedule around benchmarks and how we should think about that, related to MSSP and, some of what Liz described with what they're testing in ACO REACH. So I think there is active engagement and exploration on these topics.
So Liz, please pick up on that. What is your thinking? What is the Innovation Center's thinking at this point?
Yeah, I think our thinking, I believe, is fairly transparent. We need to move towards an administrative benchmark. It's something that MedPAC's recommended. We think it provides more certainty. We also think it's a way to grow the program with more predictability. I think, it's not easy to get from here to there, though. But you have to think, if we don't change the way that we think about setting benchmarks, as MA becomes a bigger and bigger part of the program, you're teeing off of a smaller and smaller portion of the program when you're setting these payment rates. So I think we want to make sure that we're setting accurate benchmarks and continuing to create opportunities for organizations that want to come into the program, and not just providing a place where you can come in and sort of coast if you're doing okay. So we're looking down that road. We also realized that some of what we received from the RFI was that the request for information is that, we can't move too quickly, that we need to make sure that we're doing it in a way that doesn't, I think, upset the current nature of the program as we make some of these changes. So, everything in healthcare is done, in my view, is somewhat incrementally, as that's what I've learned in my 30 years working on healthcare policy in Washington. So we'll continue to push in that direction, but it might not be overnight.
So just quickly to both of you, what process do you foresee going forward to gain additional input from all the stakeholders around this particular question of benchmarks? How can they engage in a discussion with you all going forward? Meena, quickly, and then we'll come back to you, Liz. Same request.
I think that we, from the request for information on the MA side and the request for information that Liz and her team have done on kind of that, MSSP side, I think that sets up opportunities for further conversations. I will say we have regular meetings with plans, with providers, with patient groups, with manufacturers. This is something that is really important for us. And we haven't talked about Inflation Reduction Act, but that's another area where, it is very important for us to be engaging with all stakeholders so that you can iterate on this, that you can see what the ideas are, and collectively brainstorm and then, propose, take comment, et cetera. So I think through these RFIs, through various meetings, when Liz and I travel and go and do site visits, right? And you kind of see how things are on the ground. And then through the notice and comment rulemaking process as well, I think there are lots of opportunities where we are eager to continue engaging.
Great. And Liz, anything to add on that?
You know, I think, as Meena said, we have many routes into CMS through open door forums, through webinars, through listening sessions, through site visits. Our door is open. We do a lot of meetings with individual stakeholders. We do group stakeholder calls. For example, the one we had yesterday, the quarterly national stakeholder call. So there's a lot of ways to make sure that your voice is heard in the work that we do and represented.
Great. Thank you both. So staying on the topic of Medicare Advantage for a moment, MA plans obviously are paid more or less on what could be described as a risk-adjusted capitation model. But at the very basic level, the basis of the model is still very often fee-for-service, and that most providers are paid by plans on a fee-for-service basis. So, Meena, what opportunities do you think exist for really pushing MA to be more of a true value-based model where enrollees in MA plans truly are in accountable care relationships with their providers?
Yeah, I'm happy to start, and then I'll turn to Liz. I think this is where we got a lot of information also through our request for information, and where we do want to drive the work in Medicare Advantage. So one aspect of that is our star ratings. How can we make sure that the star ratings program is driving improvements in quality and advancing health equity? So you may have seen in the recent proposed C&D rule, we've proposed a health equity index to reward care for underserved populations. And this comes to another point that we've been talking about of alignment. Where can we better align Medicare Advantage with, for example, the Medicare Shared Savings Program and CMMI models, so that you're really driving change in the same direction? I mean, I know as a provider, leading these programs as a provider where you had a big spreadsheet with all the various metrics and parameters that were different across all these different programs, where you can align will really help galvanize and drive change on the ground. So the health equity index that we're proposing in Medicare Advantage is very similar to the health equity reward that I mentioned that we have now put into the Medicare Shared Savings Program. And so being able to utilize those avenues to really drive that value-based care in an aligned way. And this is where we want to continue to engage with plans, with providers, with patients, because ultimately this is for patients. And, you know, to be able to gain more information of where we can move in that direction, and also partnering with the Innovation Center, where they are testing new ways of providing care in Medicare Advantage, particularly with their VBID model. So, I mean, I'll turn to Liz to speak more.
Great. Liz, build on that.
Yeah, I think, you know, you raised a good point, Susan, which is that we pay a capitated rate to Medicare Advantage, and then they pay fees based on fee for service. And that's not the accountable care that we're looking for, the sort of patient navigation. We really do want to see value even as it's delivered by MA plans. And we know that not all MA plans are living into that potential promise of the benefits of value-based care. So we're looking more closely at that, I think, from the CMMI angle. We're also, as you mentioned, we have a model in the Medicare Advantage program called VBID, or value-based insurance design, that gives plans more flexibility to be able to target benefits to the beneficiaries who need it most. That's mostly taken the form of clinical interventions and social determinants of health, addressing social determinants of health, where plans can target nutrition benefits, transportation, and other benefits to those beneficiaries who might be most in need, which tend to be the underserved populations. And I think we're collecting data, and we have plans to expand that program, working closely with Meena and her team to see what we might be able to learn that might be incorporated, hopefully someday, back into the MA program writ large.
Great. Thank you. And Meena, one other aspect of change that you all have proposed for star ratings is essentially to take a step back from a change that was made previously to more heavily weight patient experience and complaints in the MA, in the star ratings, and moving back to a position of reducing those weights. Talk a bit about why you all have made that decision.
Sure, and a lot of this is in response and incorporating feedback from the comments that we have gotten, both through that request for information and also engagement, as Liz and I have been talking about, that we do, out in the ecosystem, where we want to make sure that we're achieving a balance, where we are driving improvements clinically with patient experience. And to be able to make sure that we're striking that balance, we have this proposal, and we will, take comments accordingly. But that's kind of to be able to have that balance with the, clinical outcomes alongside the patient experience. And building on a theme that we've been talking about through this discussion is that each policy that we're talking about is a piece of a whole picture. And where am I going with that? So patient experience and enrollee experience also comes to play with the marketing provisions in our proposed rule, where we had heard and received information about rising marketing complaints where people were feeling that they were being misled. And so we have proposed to rein that in by having limitations on how the Medicare logo and name can be used to try to prevent misleading marketing, that marketers have to say the name of a specific plan so that people don't think that that is the universe. And similarly with prior authorization, where there are opportunities to have clearer rules of the road so that people are able to access the medically necessary care they need. And so patient experience and enrollee experience permeates throughout the policies in our proposed rule. And we really have put people with Medicare at the center of these provisions. We want to make sure, I think collectively, we all want to make sure that Medicare Advantage and all of our Medicare programs are serving the people who rely on them to stay healthy and well.
Great. Let's turn to a question that has really dogged the entire value-based care enterprise, certainly since the Affordable Care Act, if not before, which is how do you get more payers than just the public programs involved in value-based care. And frankly, we also have to include Medicaid because there has not been as much participation overall of Medicaid in value-based care as might be desirable. And Liz, I know you've been thinking a lot about multi-payer alignment all along, a consistent theme that we've heard as part of the strategy over and over again. Multi-payer models to date just have not been all that successful in attracting much participation, particularly on the commercial side of the house. So where do you think we go from here? What has the most prospect of building this multi-payer alignment among commercial plans as well as the public programs?
Well, as you mentioned, it's a central part of our strategy, but I have to be honest, I feel like we haven't made as much progress as fast as I thought we would in this area. And to no surprise to anyone who's listening on the phone, it's a lot harder than it sounds to align payers across the system. And that includes, working with commercial payers and Medicaid, even within our own house at CMS, working closely with Medicaid and with Medicare Advantage. All of these, there's different time frames for when bids are due, how decisions are made, when benefits are decided, when the payment cycles. And I think it's not that we've given up, but we are continuing to press on that. But, health system change is a marathon, not a sprint. And I think we're not giving up, but it really has, I think, eluded us to date. I am excited that, and Meena can talk a little bit more about this, that we are trying to get our own house in order in terms of how we measure and report quality. And so maybe I'll let Meena take it from there to talk a little bit about that, because I think her team has been more centrally involved.
Great. Meena?
Great. Thank you, Liz. And alluded to this before about that alignment of our quality measures across our programs. Again, just taking from my own personal experience of trying to make sense of, all of these different quality metrics across programs, where as part of CMS's national quality strategy, we really are aligning across all the various Medicare components, the fee-for-service, the Medicare Advantage, the Medicare Shared Savings Program, and the CMMI models, with Marketplace and Medicaid, so that we can really then drive change on the ground in the healthcare system. So encouraging more alignment through our programs that can then have those ripple effects in terms of how quality improvements are made. And I also think that by doing that alignment, it presents an opportunity to more easily identify gaps and where we want to go next, right? If you're sorting through, well, is it hemoglobin A1C greater than 8 that means an uncontrolled diabetic, or hemoglobin A1C greater than 9, there could be a patient-reported outcome that needs to be developed for diabetes, where some of the alignment will enable us to better identify gaps that exist and really spur that next round of quality measurement development so that we can drive towards our goals of advancing health equity and really making sure that we're thinking about full health of a person and not just, some episode of care.
Great. So we have one more polling question that we're going to take now before we move to the final phase of our discussion, which will be about an incredibly important topic, which is the Inflation Reduction Act. And then we'll move to take some of the really terrific questions that are coming in from our audience. So Eric, let me toss this last polling question now to you.
Thank you so much. In 2023, will your organization place an emphasis on shifting to value-based care payment arrangements? For responses, we have A, we've already made a shift to risk-based payment arrangements. B, yes, have some risk payment arrangements and will continue to expand this form of reimbursement in 2023. C, not yet, but it's one of our top priorities for 2023. D, no, we are not planning on entering any new value-based care payment arrangements in 2023. And E, I don't know.
Okay, let's see what the answers are. So it looks like we've got a lot of don't knows, of course, were not applicable. So leaving those out, we've got some, but also a significant number saying it's one of our top priorities for 2023. And I'm sure that's music then to Meena's and Liz's ears. So thank you for all of that. And we've now completed our polling questions for CPE and other purposes. So as I mentioned, we're going to move now to the topic of the Inflation Reduction Act, which was, of course, enacted in August of last year, many provisions of which, despite the nomenclature, Inflation Reduction Act, pertain to prescription drugs. And I guess the one inflation connection there is they were related to prescription drug pricing. This is now fully a part of the Medicare program. And for all good reasons, since obviously affordability of medication has a direct impact on the success of value-based payment models. So just to briefly recap for our audience, in case you aren't immersed in all the details, the IRA authorizes Medicare to directly negotiate drug prices for certain high expenditure single source drugs that are covered under either Parts B or D of the program. CMS this year has to publish the list of the first 10 Medicare drugs, Part D drugs and B drugs selected for the Medicare drug price negotiation program. The effort is going to be to come up with a so-called maximum fair price for those drugs, and prices for those based on that negotiation process will take effect in 2026. A separate provision of the IRA basically imposes a requirement on pharmaceutical manufacturers if they raise their prices for drugs that are used by Medicare beneficiaries faster than the rate of inflation, they will have to start to pay rebates to the Medicare program. And that provision takes effect in this year, in 2023. So all of this is moving now on a very rapid implementation timeline. And that's really where I want to start the questioning around implementation of these very dramatic changes in the program. Meena, you mentioned a while ago how important consultation with stakeholders is going to be as these arrangements are put into place. So let's talk about what you most want to hear from stakeholders, including potentially some of those on this call at the moment.
Absolutely. And Susan, you mentioned the tight timelines. We hit the ground running with implementation in the Center for Medicare. So as you may know, starting January 1st, people with Medicare prescription drug coverage will not have to pay more than $35 for a month's supply for each covered insulin product. And they can get recommended vaccines at no out-of-pocket cost. We also put in place last October a bump up in payments for biosimilars. So, kind of the generic, version for biologic drugs, again, to encourage, that market competition. That was a deadline for last October that we hit. Moving forward, you mentioned the drug negotiation. We put out a memo and a timeline a few weeks ago to really lay out what does standing up and implementing the Medicare drug price negotiation program entail, and where are the opportunities where we need to hear from all of you as we're standing this up to be as thoughtful as possible so that we can achieve the balance of access, affordability, and innovation. So we have monthly technical calls with plans, monthly technical calls with manufacturers. We have regular strategic policy conversations across patient groups, providers, plans, manufacturers, and we will have these opportunities where we're going to be asking for further comment as well, because it is very important to hear from everybody who will be impacted by this law. And the last point is, just as we want to hear from everyone as we are thinking about how to best implement, we also need partnership on the ground for that implementation. So, for example, with the provisions around insulin and vaccines, that really has been in partnership with plans who have had to make adjustments to, their benefits, to pharmacies, so that people are getting the right out-of-pocket cost, at the point of sale. And to many patient groups, our insurance and health navigators, who are explaining these benefits to people with Medicare so that they can take advantage of them. So really it is an all-hands-on-deck effort.
Great. And Liz, obviously, CMMI is going to play a role as we pay more attention to prescription drugs in the context of value. And you all were directed by an executive order from the president last fall to begin to articulate models that also will incorporate drug pricing issues into them. What do you think is ahead? I know you all are about to put out a report on this topic. Can you herald for us what you might say about the additional opportunities to incorporate prescription drug pricing into CMMI models?
Sure. Well, first, let me say the Innovation Center is really proud of the model we tested to offer Part D coverage of insulin at $35 or less a month. And this model, the Part D Senior Savings Model, served as a blueprint for the provision included in the Inflation Reduction Act that just went into effect and that Meena described. We're building on that success and living into the executive order that the president signed in October, directing us to identify new possible models that have the potential to lower drug costs and promote access of innovative drug therapies. In response, like you said, we've submitted a paper outlining model concepts and areas for additional research to the White House, and soon we'll be able to make that public. But let me just add that Meena and her team are hard at work implementing the Inflation Reduction Act, and that is the main stage. Whatever we do will be complementary and build on those efforts, but we want to make sure one of our principles is making sure that we don't do anything that impedes these efforts. So I think you'll see that when the report comes out, but let's keep our eyes on the main stage, which is implementing successfully the Inflation Reduction Act. But we look forward to being partners in this area as well.
So just one more question on the maybe the non-main stage. Some have suggested that you all could take what was known as the senior savings model, which actually tested this notion of lower insulin out-of-pocket costs, which has now been incorporated into the IRA. Some have suggested you could apply that to other therapeutic areas that have high costs that are imposed on beneficiaries. Is that possibly in prospect?
Well, I think, again, going back to the Inflation Reduction Act, that is the main stage, and the Inflation Reduction Act made really significant changes to the benefit. So anything we do needs to be taking into account both the changes made to the benefit and the timeline that those changes are going to be implemented. So I think whatever we were looking at before the IRA passed, I think is probably going to be informed by some of the changes in the law and by the work that's ongoing in the Center for Medicare. But I will say what we thought was successful about the model was that it was voluntary, that we had a significant portion of providers or plans at the table participating in the program, and all the manufacturers were at the table as well on a voluntary basis. And I think that's part of what set that program up for success. And so we're looking down the road of what we could do to build on that success, but also keeping in mind the Part D benefit changes that are really it's a huge undertaking to change that benefit. So we need to make sure that whatever we're doing is in conjunction with that effort. Great.
Well, thank you. Well, we're now going to go to a number of the audience questions, and I'll start by with a couple of them. One questioner has posed this one. Is the move to value predicted to jeopardize cost-based reimbursement for critical access hospitals, who of course have been paid under the separate component of Medicare payment, in effect, cost-based reimbursement? Is that at all in jeopardy? Meena, let's put that one to you.
Thanks. I think our goal is to work with all providers in these value-based arrangements. So we're working very closely with HRSA, for example, with FQHCs, with rural health clinics, where we really want to address the needs of the wide variety of providers and diversity of providers that are out there, because that is the way that we're going to move the needle overall, with the healthcare system. And so where there are insights and inputs that can help inform what we do, we definitely are eager to hear.
But at least in terms of near-term alterations in cost-based reimbursement for critical access hospitals, on the table, not on the table?
Well,
were you going to say something, Liz? Oh, no, okay. Well,
I was going to say that's a statutory payment. So
that's what I was just about to say. That is something that's statute. So, hearkening to something I had mentioned earlier, where we always look to see what is the Medicare law, and within the Medicare law, what are authorities and discretion that we have.
I do want to add to that, because I think, we had a rural health model, and we found that rural health providers are really in a state of, considerable jeopardy right now, where there's a lot of crisis going on in among some of these rural providers. And I don't want to make light of that at all. So the model that we had that looked at bringing on rural health providers and rural hospitals into value-based care, they weren't ready to take on risk, and they weren't ready to move into a new payment model. They're looking for stability and predictability, and we recognize that, and there are alternatives that don't necessarily, I think we can't change the dynamic that's created under this pure fee-for-service, but there might be ways that we can think about addressing some of their concerns that provides still a flexible but predictable model. I will say also that 74% of, or some proportion of, rural hospitals that have closed are in states that haven't expanded Medicaid. So you also have to consider the issue that many of these providers are operating in areas where a higher proportion of the population is uninsured. And that's not something that CMMI or the Center for Medicare can fix.
Right. And the gist of your comments earlier are, as you said, the Critical Access Hospital Program is in statute. It would be up to Congress to change any of that going forward. Okay, let's move to another question.
Susan, I think we've hit the end of our time limit here. I hate to stop this because it's such great information. It's so substantive, but unfortunately we are going to have to stop here and try to address some of these questions offline. But
Okay.
I definitely want to thank Susan, Meena, and Elizabeth. This was really just a splendid conversation, and thank you for your time. I know everybody very much appreciates it. Susan, any last words before I wind us up?
No, thank you very much. I'm sorry that we are out of time. There were some excellent questions here, but as you all saw, we had a lot of content to get through. I just want to say a special word of thanks once again to Meena and to Liz for their work, their leadership at CMS and CMMI as we try to steer the country to a saner, value-based healthcare system. So thank you again for the honor of leading this conversation. And Eric, thank you as well.
Absolutely. Thank you for conducting that. That was really great. Just a reminder that there's a lot of resources available to you from Moss Adams. They're listed on your slides here. We have the on-demand webcast we talked about earlier. And a reminder, you can sign up for be on the mailing list for our next conference. With that, I'm going to turn it back over to Amy to close us out.
All right, thank you, Eric, and thank you all for a really great discussion today. I wish we had more time. I do have a couple housekeeping items for our audience. If you met all CPE requirements, your certificate is available to download now in the CPE progress window. A copy will be emailed within 2 weeks should you have difficulty downloading it now. And as a reminder, if you attended today's presentation in a group and would like to receive CPE credit, you must complete the group attendance sheet that's found in your console. And finally, here's a link to an online survey for today's presentation. And thank you for joining our webcast. Take care, everyone.
Bye-bye.
Thank you.